Causes of death associated with anesthesia and surgery. Causes of general anesthesia and operative death, death associated to anesthesia, death associated to surgical operations, surgeons going through the sternum involuntarily, death by disease, those for which anesthesia was given for, or operation performed. Emergency operation, a highly serious condition for which a large last-ditch attempt was made through surgery, explosive injury with extreme fragmentation, high-risk operation, coronary artery bypass graft, heart transplantation operation, other than the for which anesthesia was given, operation given or operation performed, hypertension, ischemic heart disease, lung disease. Incidence. When mortality from anesthesia began to seriously studied in 1950, the mortality rate was about 1:2 when those anesthesia admitted otherwise healthy patient. The malpractice premium for anesthesiologists was about high as that of surgical specialties. However, due to introduction of sophisticated monitoring devices before better training and understanding of the physiological effect of anesthesia and better transmission of information concerning cause of anesthesia mortality rate has fallen to a range of 5 to 6 million per anesthesia administration. At the same time, malpractice premium has fallen close to the range of primary cause physician, while death due to anesthesia is generally difficult to declare thus due to surgical open due to death associated with anesthesia inexperience. Many deaths occur due to inexperience and failure to adopt precaution when clearly indicated. Inadequate depth of anesthesia. Intubation and bronchoscopy may cause a vagal inhibition if depth of anesthesia is inadequate. Inadequate ventilation, hypoxia, sudden death due to heart failure. Post-operative respiratory obstruction by tubing or swab, breathing circuit disconnection between staff, hazard distraction and excessive pressure on airway. Rupture of lung, positive pressure ventilation converts a simple pneumothorax into tension pneumothorax. Intubation of esophagus instead of trachea. Clinical factors: under ventilation, low blood volume, inadequate transfusion, anoxia causes cerebral damage, involuntary hypothermia, hyperpyrexia, inhalation of regurgitated material, vomit, especially during the postoperative period. Technical mishap, administration of incompatible blood, infusion of a wrong drug or fluid, sodium citrate form normal saline. They are both colorless and have virtually similarly labels. To avoid such errors, use distinct labels and keep in separate cupboard and anesthesia for a greater strength than required. Either injected or an error for a local anesthesia. Label should be checked as well as order to prevent such incident. Administration of adrenaline in error of cocaine. Equipment failure, inadvertent inhalation or gauze or other swabs. Dangerous, mislabeling of oxygen and anesthetic gases. Explosion and fires. Ignition of inflammable anesthetic vapor by an electric spark. Most dangerous inflammable mixtures are cyclopropane, oxygen and ether oxygen. The spark may arise from a faulty electrical appliances, X-ray apparatus, static electricity, or from a surgical diathermy electrode. Common adverse reaction associated with anesthetic agent: Althacid, violent bronchospasm. Anaphylactic reaction, dextran, latex containing gloves may lead to an allergic response when the surgeon put his hand into the patient's body. Atropine used in pre-medication can cause hypoxia, especially in the presence of respiratory and cardiac diseases. Can cause hyperpyrexia through interference with the heat-regulating mechanism. Barbiturate, IV overdose, chloroform, hepatotoxic, rarely produces ventricular fibrillation. Anesthesia, most common cause of death under anesthesia is acute neurogenic cardiovascular failure. Acute neurogenic cardiovascular failure. Halogenated hydrocarbon, example cyclopropane, halothane, trichloroethylene, cause cardiac irritability or by sensitizing myocardium to the action of adrenaline. Halothane, hepatotoxic, liver necrosis, malignant hyperpyrexia. IV infusion can cause air embolism, can occur during surgical procedures. Lignocaine may cause generalized convulsions and death. The lignocaine cause generalized convulsions and death. Myoneural blocking agents, blood drugs, respiratory inadequacy, nitrous oxide. Death is rare but occur due to overdosage or when contaminated with nitric oxide. We can also aid pneumothorax to expand rapidly. Careless use of relaxant drug, curare, with IV barbiturate, paralysis of respiratory and throat muscles. Suxamethonium, hyperpyrexia, suxamethonium without atropine, fatal bradycardia. Thiopentone, if used in elderly and atherosclerotic patient with ischemic heart disease, may cause circulatory collapse. Trichloroethylene, heart failure, IV administration. Urea, hypertension, overdose of anesthetic agent, depression of the respiratory center, malignant hyperpyrexia, malignant hyperthermia. Malignant hyperpyrexia, malignant hyperthermia, or malignant hyperthermia syndrome is a rare life-threatening condition triggered by exposure to certain anesthesia, specifically all volatile anesthesia. Nearly all gas anesthetics and neuromuscular blocking agents, accompanying silent features. Susceptibility to malignant hyperthermia is inherited as an autosomal dominant disorder. Incidence and mortality: 1 is to 5,000, 15,000 pediatric anesthesia, 1 is to 50,000 adult anesthesia. Mortality is about 10%. Before the introduction of dantrolene in the late 1970s, the mortality was close to 80%. More occurs more in a pediatric patient because many older people will have already had surgeries, thus would know about and able to inform the doctor for their condition. Signs and symptoms: muscular rigidity, followed by a hypercatabolic state with increased oxygen consumption, carbon dioxide production, hypercarbemia, usually measured by capnography, tachycardia, fast rate, heart fast rate, increased body temperature, hyperthermia at a rate of up to 2 degrees per hour, temperature up to 42 degrees Celsius, not common. Rhabdomyolysis may develop as evidenced by red-brown discoloration of the urine, and cardiological and neurological evidence of electrolytic disturbance. Test: there is no simple straightforward test to diagnose the condition. Treatment: dantrolene sodium for a malignant hyperthermia. Death associated with a surgical operation: it is generally accepted that once the patient has recovered consciousness, has been restored to this condition prior to the administration of the anesthetic. The anesthesia not responsible subsequent death. It must be due to another reasons. Causes of death to surgical operation include inexperience, inadvertent mechanical disruption of vital organ during a procedure, catheter being passed into the coronary artery, right atrium, right ventricle, pulmonary artery perforates through, air embolism occurs most commonly, surgery of the CNS, embolism of cerebral venous sinuses, but when they are opened in a sitting posture during laminectomy procedure, operation in the region of the axilla are associated with anesthesia, massive hemorrhage from slipped ligature, uncontrollable using, accidental perforation of a viscous nosocomial infection, death by disease. Majority of cases of death associated with anesthesia. The cause of death is a disease. There are two broad groups: those for with anesthesia was given polytrauma, severe biochemical disturbances due to prolonged acute intestinal obstruction. Other than those for which anesthesia was given, ischemic heart disease, previous emboli in a calf veins may get mobilized and cause pulmonary embolism, is especially for operation of the lower limb. Previous cardiac infarct may cause hemopericardium, adrenal hypoplasia, sudden collapse due to hypotension, pheochromocytoma, fulminant hypertension, tension, pneumothorax from rupture of emphysematous bullae. Thank you.